Good morning, everyone. SNF training for me is always like old home week, right? We all know each other. Tom had stressed, I've been in this a long time. You guys have all been in it a long time with me. So good morning. I am going to talk to you about Section M. And those of you who know me know this is my favorite section of the MDS and something I've been talking about, again, for a long time. So in this presentation, we are going to look at the updates. Deb mentioned a lot of the changes that have occurred with Section M. Many of the changes involve removing those items, which is neat. We don't usually have lots of things removed, but we did this year in Section M. And you'll also see that definitions have been updated to reflect changes in the 2016 National Pressure Ulcer Advisory Panel, or NPUAP, pressure injury staging system. As in earlier versions of the manual, these definitions are adapted, so they're not exactly the same as they are with the NPUAP. You'll also note the integration of the word pressure injury rather than just pressure ulcer in the manual and the item set. I do want to just draw your attention to a couple of things. In your packets, if you're an online participant, it's your packet that is Section M, Skin Conditions Updates. And in addition to the PowerPoint, you have the Practice Coding Scenarios Section M Without Answers is what it's called. And for those of you who are here in the room with us, you have that in your packet as well. What it allows you to do is have the coding scenarios in front of you before you actually, as you're doing the polling, so you're able to look at that. So that should actually be in the folder that you received when you came in, so you should be able to use that. We do have quite a few polling questions in this section. So I encourage you to get involved with those. I also am very happy to entertain questions when this section ends. In each of our presentations today, you'll find an acronym list. We certainly aren't going to read those to you, but they are embedded within the PowerPoint. And then also within your packet, you'll find a comprehensive list of all the acronyms that were used in the session, so feel free to pull that out and refer to it. And that is available in the introduction packet if you're an online participant. So what are we going to talk about in this section? I'm going to explain the intent of Section M and discuss some updated coding guidance. There's lots of practice scenarios. And then I'll explain to you the, the cross-setting pressure ulcer measure, which is changes in skin integrity post-acute care, pressure ulcer injury, and how that measure is calculated. You'll notice that the slides for this section of the training include updated guidance rather than complete coding guidance. So, for example, I'm going to look at the steps for assessment with you in a little bit, and you'll see that there are just excerpts of those steps. This would be a huge set of slides if we included everything there. So I'll refer back to pages and things that you'll be able to take these back and use them when that manual becomes available so you can more fully understand Section M. Here are our objectives for the training after the session. I hope that you'll all be able to identify the intent of Section M, articulate the purpose of the new wording and any implications that has for coding. You'll be applying coding scenarios. We have quite a few, and that you'll recognize the elements of that cross-setting pressure ulcer measure. So let's start with looking at the Section M intent. There has been one change in the intent of Section M, and that is the addition of the word injuries to the first sentence. So where it states the items in this section document the risk, appearance, and change of pressure ulcers / injuries. And then CMS does go on to stress in that intent the importance of identifying and evaluating risk factors, as well as evaluating areas at risk for pressure. Next, the intent stresses the importance of a complete skin assessment and a holistic approach that informs the plan of care for the resident. And the final bullet on this slide is a very important one. Clinicians must accurately identify wound etiology. This is vital to ensuring accurate documentation, including on the MDS, and more importantly, it's vital to directing the resident's plan of care. So let's take a look at the item changes, and there are quite a few. And similar to what's been in the manual before, CMS acknowledges that there is a wide array of terms to describe skin alterations that are due to pressure. And these go from long ago terms like decubitus ulcer and bed sore to pressure ulcer and pressure injury, among others. So regardless of what the documentation is in the medical record, using any of these terms, clearly an alteration in the skin due to pressure is going to be captured in Section M as such. Another important point is the change of pressure ulcer to pressure ulcer / injury, and that was made to better describe the presentation of tissue injury as open ulcers versus tissue injuries that present as intact skin. And it stresses that regardless of the term, as I mentioned before, used in the medical record, you should be coding appropriately in Section M for pressure. And you'll note on this slide the addition of the word injuries in several areas on the item set, and let's look at that a bit more closely. Stage 1 pressure injuries and DTIs are termed pressure injuries as they are closed. Stage 2 through 4 and unstageable ulcers due to slough or eschar are generally open, so they are termed as pressure ulcers. Unstageable due to a non-removable dressing or device could be either. So these are referred to as pressure ulcers / injuries. Additionally, non-stage specific references are ulcer injuries, such as in M0150, when the item set asks about risk of pressure ulcer / injury. In M0300E, the item was updated to include device in the bolded text in the first part of the item following the letter E. And in M0300G, the phrase suspected deep tissue injury and evolution was changed to deep tissue injury. And Deb already mentioned to you that several items have retired. So the date of the oldest stage 2 pressure ulcer, the dimensions of the unhealed stage 3 or 4 or pressure ulcer covered with eschar, and the most severe tissue type have all been retired because they're not used in any of CMS's programs, and it was deemed as additional burden on providers to collect that information. Additionally, M0800, worsening in pressure ulcer since prior assessment, and M0800, healed pressure ulcer items are being removed because the present on admission items that you code on the discharge assessment will be able to identify which of the pressure ulcers have increased in numerical stage or become unstageable and whether or not an ulcer is healed. So essentially those M0300 items capture that information that those two items were providing. There have also been several changes in coding guidance. Let's take a look. With removal of several items from Section M, some definitions and guidance were moved to other Section M locations. Any remaining instructions that did not apply to items were removed, and skip patterns have been updated to reflect the removed items. There have been two changes in the pressure ulcer risk factor definition. These include the addition of injury, so that the concept being defined as pressure ulcer / injury risk factor, and microclimate was added as an example of a risk factor. This was also added in the list of external risk factors in the discussion of the item rationale. Microclimate was defined in a program, a presentation by Dr. Laura Edsberg. It was a 2015 NPUAP presentation where Dr. Edsberg defined microclimate as temperature, humidity, and airflow at the patient support surface interface. There's certainly an expanding body of information regarding microclimate. What is evident is that microclimate has a significant influence on an individual's risk for pressure ulcer or injury. As in previous slides, the bold italicized font on these slides indicates new additions to definitions or other guidance. In the phrase intense or prolonged pressure, that was added to describe the pressure. We understand that it's not only prolonged pressure, but intense pressure at for a short time can also lead to pressure injury, and this change is consistent with that clinical concept. The last sentence that states the pressure ulcer injury can present as intact skin or an open ulcer and may be painful was also added. Additionally, the phrase and or friction was removed. It used to say pressure in combination with shear or friction. Keep in mind, again, that this definition is adapted from the 2016 NPUAP definition, so that has been kind of realigned to be more clinically in line with that definition. As I mentioned, the term microclimate has been added to the item rationale for the determination of pressure ulcer or injury risk. And microclimate influences the susceptibility of skin and soft tissue to the effects of pressure and shear. And it's important that nursing home teams are cognizant of that risk factor and take steps to care plan appropriate interventions and put those interventions in place to address the issues related to microclimate. There were several updates to M0210's Planning for Care section. This reference to the staging system was updated to reflect the NPUAP's 2016 staging system that was used as the basis for the definition. An injury was added in a couple of places. Additionally, the importance of visual appearance informing staging decisions can't be overstated, so the description of a staging system now includes the phrase visual appearance and or anatomic depth of soft tissue damage. Excuse me. On this slide appears a completely new planning for care tip that reinforces the need to reevaluate the plan of care with a new or worsening pressure ulcer. Excuse me. To ensure that the most appropriate plan of care to treat the pressure ulcer injury as well as to prevent additional ulcers is in place along with those, again, preventative measures to keep the rest of that resident's skin healthy. The first coding tip on this slide states that if two pressure ulcers or injury occur on the same bony prominence and are separated at least superficially by skin, then count them as two separate ulcers. Stage each and measure each, and again, document them separately. You may recall the last coding tip on this slide. The manual previously stated if a resident had a pressure ulcer injury that healed during the look-back period of the current assessment, but was not documented, there was no documented pressure ulcer in the prior assessment, code 0. But that tip has been updated, and I think this is a pretty significant change in the guidance. That now it says, so that second part of the tip that stated, and there was no documented pressure ulcer on the prior assessment, code 0 was removed. So now the tip is exactly what you see here on the slide. If a resident had a pressure ulcer injury that healed during the look-back period of the current assessment, do not code the ulcer injury on the assessment. So what part of that went away? The requirement to have had it coded on the prior assessment. So that to me is a big change in this, and I think that was a tip that folks often struggled with for a lot of years, and now it's a little more simple. Y'all doing good? Still with me? Yep, okay. So the 3 steps for completing M0300A through G likely look very familiar to you. First, determine the deepest anatomical stage, then identify unstageable pressure ulcers, then determine which of those ulcers or injury were present on admission. The definition for on admission has not changed. It means as close to the actual time of admission as possible. Your facility protocols and clinical practice guidelines likely inform what that time means in your facility. Is that fair? Yeah. Each of these steps has been updated, and let's take a look to see what those updates are. So, in an effort to spare you some incredibly wordy slides, we just made a note that manual instructions 3 and 4 under step 1, which we're referring to backstaging and reverse staging, were added. And I am going to just share those tips with you so you can take a listen to those. And again, I welcome questions on these when we're done with the presentation. So the first tip, which is number 3, again, that's been added under that first step, which is identify the deepest anatomical stage, states that pressure ulcers do not heal in reverse sequence. That's not news, right? That is, the body does not replace the types or layers of tissue. For example, muscle, fat, and dermis are not replaced as that ulcer heals, that were lost during pressure ulcer development before they reepithelialize. Stage 3 and 4 pressure ulcers fill with granulation tissue. This replacement tissue is never as strong as the tissue that was lost, and hence this area is more prone to break down forever, right? And that's, I think clinically we all acknowledge that. The 4th tip is even longer, and it's got a ton of clinical information in it, and again, I'll just share that with you. Clinical standards do not support reverse staging or backstaging as a way to document healing, as it does not accurately characterize what is occurring physiologically as the ulcer heals. For example, over time, even though a stage 4 ulcer has been healing and contracting such that it is less deep, wide, and long, the tissues that were lost, and that is muscle, fat, dermis, will never be replaced with the same type of tissue. Previous standards using reverse staging or backstaging would have permitted identification of such a pressure ulcer as a 3 and then a 2 and then a 1, and then we would say it was healed. But clinical standards now require that this ulcer continue to be documented as a stage 4 until it is completely healed. And nursing homes can document the healing of pressure ulcers using descriptive characteristics of the wound, that is the depth, the width, the presence or absence of granulation tissue and the like, or by using a validated pressure ulcer healing tool. Once a pressure ulcer is healed, it's documented as a healed pressure ulcer at its highest numerical stage. For instance, a healed stage 4 ulcer. For care planning purposes, the healed stage 4 ulcer would remain at increased risk for future breakdown or injury and would require continued monitoring or preventative care. That's quite a tip, huh? Quite a mouthful. What's the biggest risk factor for that patient or resident for having a pressure ulcer? Having had a previous one, right? We know, number 1, top of the heap, that we're worried about those residents. The definitions for epithelial and granulation tissue were also added in this section. So epithelial tissue is new skin that is light pink and shiny, even in persons with darkly pigmented skin. In a stage 2 ulcer, epithelial tissue is seen at the center and at the edges. And then in stage 3 or 4, so full thickness wounds, that epithelial tissue advances from the edges as that wound fills in. In granulation tissue, nurses are the only people that say, oh, look, it's all red and bumpy. Doesn't that look great, right? That's what granulation tissue is. It's red tissue with that cobblestone or bumpy appearance. It bleeds easily when you're injured. Your patients' families are like, why are you happy it's bleeding? And you're like, because a week ago there was no blood flow. Yay, it's doing great. And again, we want to see that and want to see those nice healthy wounds. Instruction 2 under step 2 was added to reinforce the point that the ulcer should be cleaned prior to staging. If after it's cleaned, the anatomical structures remained obscured such that the clinician can't determine the extent of the soft tissue damage, the ulcer is unstageable. So what if your ulcer is 80 or 90% covered with slough, but you can see a tendon? Is that stageable? Sure, right? You can see an underlying structure. It's a stage 4. Doesn't mean you can measure it fully. It doesn't mean you can, you don't have some stuff going on there, but you can see the base of that ulcer. You can see that structure. Instruction 6 under step 2 provides additional information that in order to code a pressure ulcer injury as unstageable due to non-removable dressing or device, it must be known, in quotes, that there's a pressure ulcer injury under that device and it must appear in the documentation. There are some new instructions regarding determining present on admission. And again, this is where I would note that there's a pretty significant change. I shouldn't use the word significant change, right, in MDS training. Whew. Yikes. That was a bad one. Manual instruction 4 under step 3, if the pressure ulcer injury was present on admission or entry, or re-entry and becomes unstageable due to slough or eschar during the resident's stay, the pressure ulcer is coded in M0300F and should not be coded as present on admission. So what did we do in the past? We said we have a stage 3 or 4, it becomes unstageable, you wait and see what happens once it becomes stageable again to compare, have these declined or what's going on under there. And we've always said, but we know if it's covered with eschar or slough, it's clinically worse, right? We're worried about it. So now the MDS aligns with that. If it's a stage 3 or 4, or any ulcer that was stageable, now it's unstageable due to slough or eschar, it will not be coded as present on admission, okay? Likewise, if a resident with a pressure ulcer injury goes to the hospital and returns with an unstageable pressure ulcer injury or an ulcer injury of a higher stage, you would code it present on admission. So if you discharge your resident, they have a stage 3 pressure ulcer, they go to the hospital, excuse me, they come back a week later, excuse me. Now that stage 3 pressure ulcer is covered with slough, you can't stage it. Now it is an unstageable present on admission. Okay, and then you'll determine, once again, you can unroof that, you can see what's underneath that, then you can determine that stage as appropriate. Oh, what did I do there? I think I went backwards, sorry. Okay, and manual instruction 9 under step 3 that addresses numerically staging ulcer that becomes unstageable and subsequently is debrided, that it can be staged and is a higher stage, again, consider it not present on admission, and this is that example. This is not a new instruction, this was just moved, and again, is worth mentioning. Similarly, this tip is not a new tip, it was just moved, and that is instruction 10 under step 3 that addresses when 2 pressure ulcers merge. In the case of 2 pressure ulcers that were present on admission merging, continue to count the single larger ulcer as present on admission unless it increases in stage or becomes unstageable due to slough or eschar. So again, nothing new with that. So the present on admission items, and those are M0300B2 through G2, address whether the pressure ulcer injuries were present on admission or acquired or worsened during the stay. When we say subsequent assessment, it could mean another PPS assessment, it could be a discharge assessment, It's important to note, however, when we look at that QM later on in this section, that the QM now is only going to be comparing that admission to the discharge assessment. So where we used to look at what happened on the 5-day, okay, compare it to the 14, compare it to the 30, the 60, that's not happening anymore. So it's really this kind of 2 points in time now, and you'll see that when we review that measure at the end of this session. Per page M8 of the RAI manual, if the pressure ulcer injury was present on admission or entry and becomes unstageable due to slough or eschar during the resident's stay, it's going to again be coded M0300F, and it is not coded as present on admission. And then manual page M9 is the reference for if the pressure ulcer was numerically staged, then becomes unstageable and subsequently debrided sufficiently to be numerically staged. Compare it to the numerical stage before and after it was unstageable. And again, it's increased, code this pressure ulcer as not admission, not present on admission. So again, we're looking at subsequent assessment or discharge assessment. And if that is coded as present, not coded as present on admission, it's new or worsened. And if it is coded as present or on admission, it's not new or worsened. So basically, facility acquired equals worsened, or worsening in stage. So let's look at a present at admission scenario. This is not one that you have for polling yet. We're just going to talk through this one, but we have a lot of polling to come on this section. So Mrs. J came into our SNF with a stage 4 pressure ulcer on her left hip. When the pressure ulcer is reassessed at discharge, it's entirely covered, hopefully it was reassessed before discharge too, but it's entirely covered with eschar and the wound bed cannot be assessed. Mrs. J is discharged with an unstageable pressure ulcer due to slough or eschar. So Mrs. J had a stage 4. During her SNF stay, the ulcer became completely covered with slough or eschar. How do you code this in M0300? Let's take a look. On the admission assessment, so this is when she first came in, we have nothing in stage 1s, 2s, 3s. So when you're coding 0, like in M0300B1 or C1, you code a 0, you're going to skip down to the next item because you aren't going to address present on admission if you don't have that ulcer. And then in M0300D1, number of stage 4 pressure ulcers, we're going to code it as 1 on her admission, and one of those was present on admission. And then we aren't coding anything in the unstageables on her 5-day PPS. But then on her discharge, we're coding nothing in M0300B1, C1, or D1. Notice that we aren't coding, we don't have the opportunity to code M0300A. That isn't going to be on your discharge assessments anymore, okay? The PPS discharge assessment. And how do you find out all of that stuff on what the changes are and what item set? On the link that Deb provided on the last couple of slides when she provided where all the item sets and things were, there is a change table for the MDS item sets that are coming in October 2018. So you can actually go through the item set type and know which items are going to appear on which item set. I mean, what most of you probably do is what I do is print out a comprehensive, right? Because it has everything and you learn and use that. But this way you can figure out what's going to be there and which item sets and can plan kind of accordingly, okay? So on this, in D1 here, the number of stage 4 pressure ulcers, we are coding it as 0 because remember that ulcer became unstageable. So here we code that item, unstageable pressure ulcers due to slough or eschar as a 1, and it is not present on admission. And remember, it became unstageable during her stay. So here's our rationale. At admission, she had that stage 4 on her left hip. So we code the admission assessment as 1 stage 4 ulcer, and one of those, that one ulcer was present on admission. But then the stage 4, it became unable to numerically stage it during her stay. So on discharge, the discharge assessment is coded as 0 for D, where we code stage 4s, and we are going to then skip D2, and we are going to capture that ulcer in M0300F1 as on the discharge assessment as an unstageable, and then we will count that as not present on admission. So just a reminder, this newly added instruction is going to be on page M8 of your manual, and that is if the pressure ulcer injury was present on admission or entry or reentry, and becomes unstageable due to slough or eschar during the resident's stay, it's coded in M0300F and should not be counted as present on admission. Okay, let's go ahead and look down through some coding instructions. And again, we're only focusing on changes here, not every single instruction that appears in the manual. And this item, M0300A, it's been updated to refer to pressure injuries, and the word currently was added in the coding instructions. Otherwise, it's unchanged for that stage 1. A new coding tip has been added to the coding instructions for M0300B that reinforces that stage 2 pressure ulcers do not have granulation tissue, slough, or eschar, and when these are present in previously stage 2, the ulcer has now become a full thickness ulcer. Remember that stage 2 pressure ulcers are partial thickness wounds. When they progress such that there is granulation or any of that underlying tissue, you've now moved on to a partial or a full thickness wound. There are 2 entries under planning for care associated with M0300C. These stress the importance of considering tissue characteristics of pressure ulcers when determining treatment options, and note that these characteristics are also indicative of whether the wound is on the right track, so to speak, in healing or getting worse. There are quite a few new coding examples for stage 3s as well that have been added to the RAI User's Manual, so you certainly can use those in your training of your staff. That's okay. Can't believe you admitted it was you. I'd have been like, whose phone is that? Who at their phone? Wow, she's honest. Honest girl. All right, a coding tip has been added for M0300D that addresses the importance of assessing tunneling and undermining. So what do we think about tunneling? It's kind of like a sinus tract, like a shoot off of that wound. Where undermining, I think of it as kind of, you've got your skin intact, you've got that tissue underneath, and it's kind of like a little cave in there, right? It's that kind of larger section. We usually talk about undermining as we might measure it at the clock. We would say from 12 to 5, right? Where tunneling is usually a tunnel at 1 o'clock or something like that. So it's very different characteristics. So just like other wound measurements, you're measuring tunneling and undermining. You're no longer capturing the wound measurements on the MDS, and you certainly don't capture the tunneling or undermining. And again, these aren't coded on the MDS, but they need to be assessed, monitored, and treated. Like the other pressure ulcer measurements and characteristics, these issues need to be included in the overall assessment as to whether the wound is healing or degenerating, or whether it's staying the same and maybe something needs to change. So visual inspection of the wound bed is necessary for accurate staging. Pressure ulcers that have eschar or slough present such that you can't assess that anatomic depth of the soft tissue can't be visually inspected or palpated, so the wound's going to be unstageable, classified as unstageable. Keep in mind, you're looking at what are those underlying structures, what's going on in that wound. The bold italicized portion of this coding tip was added to stress if the pressure ulcers that are covered with slough or eschar, and again, the bold part and the wound bed cannot be visualized, they'll be coded as unstageable. Once enough non-viable tissue is removed to allow inspection of the tissue damage, then you can go ahead and stage that wound. And remember, under the new guidance, stage 1 to 4 pressure ulcers or injuries that develop slough or eschar would be considered worsened. So let's take a look at some other updates. And these are updates to M1040. The updates affect 3 of the items: M1040D, open lesions other than ulcers, rashes, or cuts, and M1040G, skin tears, and M1040H, moisture-associated skin damage. The coding tip has been added and is shown on the screen in bold. Gives examples of what we might code in M1040D. Examples include other wounds, boils, cysts, and blisters. There was also an addition to the second coding tip to stress that abrasions aren't coded here. This tip is important where it says do not code rashes, abrasions, cuts, lacerations. And it says these aren't recorded on the MDS but are captured in the plan of care. I think one of the mistakes that folks, particularly if they're new to MDS, make is they try to fit everything into somewhere on the MDS, right? If you look at your hygiene item, they try to take like the entire part of like AM care or whatever and cram it all in there. And they should be just sticking with what's in the coding instructions. So the MDS is a pretty big assessment, 50-ish pages now, captures a lot of information, but everything about your patient or resident condition isn't crammed into that assessment. So don't let your staff and let those folks you work with feel the need to fit it somewhere. Some things simply don't fit on the assessment. Does that make sense? And I just discussed this tip under M1040D. It was also added to 1040G, skin tears. So cuts, lacerations, and abrasions aren't coded in this item either, but they're going to be coded in the plan of care. And then there were some additions to moisture-associated skin damage. The first bullet had this statement, and can cause other conditions such as removed. So we used to say maceration and includes other conditions such as blah, 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 and list all those. And that's been removed. Additionally, there was the addition to the note that MASD, or moisture-associated skin damage, is also called maceration. The definition that has also been updated there. Moisture-associated skin damage is superficial skin damage, and that's important, caused by sustained exposure to moisture, such as incontinence, wound exudate, or perspiration. There was an addition to the first coding tip shown on this slide that stresses the role of moisture and moisture-associated skin damage and pressure ulcer risk. Remember microclimate, temperature, and humidity. The next coding tip will help clinicians in identifying moisture-associated skin damage. Moisture-associated skin damage without skin erosion is red or bright red in color most often. The skin around it may be hypopigmented, so lighter. Moisture-associated skin damage usually has irregular edges, and it's generally blanchable. The skin may be inflamed. So what about moisture-associated skin damage moisture-associated skin damage with skin erosion? This may be hyper or hypopigmented. Tissues usually blanchable. Again, edges are irregular. There may be inflammation, but there won't be necrosis. Moisture-associated skin damage is a superficial or partial thickness skin injury. If there is a combination of pressure and moisture-associated skin damage, code the skin damage as pressure. And I will tell you, in my years of being a consultant, I worked with a lot of folks with G-level pressure ulcer or worse deficiencies who said, oh, they've got some moisture-associated skin damage. We'll put a little of this nice cream on. And a week later, the doc comes in and says, well, there is some moisture, but there's also some pressure. Right now, they get all their pressure ulcer protocols going. So there's been a delay in the care. So, I think the bottom line to me is accurate etiology up early, right? Don't wait. Don't assume it's moisture-associated skin damage. Don't not move ahead with the appropriate care of that resident, in the hope to avoid a pressure ulcer. We've got to get on top of it quick. And if there is an area of a full thickness wound that extends beyond the subacute tissue or there's necrosis, don't code it as moisture-associated skin damage. Instead, code it in M0300 as a pressure ulcer. We also have M1200G, application of non-surgical dressings with or without topical medications other than to the feet. Has a very minor change. Let's take a look. We added wound closure strips. So I'm not reading you the whole tip. There it is, no other changes to it. Wound closure strips are also known as what? Steri strips, yep. Okay, you ready for some fun? Time for you guys to do the work instead of me. And again, to make it easier for you to participate in those scenarios, you can refer to that document in your packet labeled Section M, Skin Conditions Updates, Practice Coding Scenarios. And you should have that example looking something along like this. And for those of you online, you should be able to access it in this section's electronic folder as well. And then for those of you who are in the audience, you should be able to find that in your packets. Everybody finding it? Okay, let's go. So this is when you need your phones and that Slido app. Ephraim back there at our table in the yellow shirt is the Slido king. If you have any questions, see him. He's really done a lot of awesome work on our project. You guys can thank him for all the neat interaction and stuff. So yay, Ephraim. Okay, you ready to go? Got your Slidos ready? Cool name, right? Slido. All right, a resident develops a stage 2 pressure ulcer while at the nursing facility. The resident is hospitalized due to pneumonia for 8 days and returns with a stage 3 in the same location. How would you code M0300C1 and M0300C2 on the 5-day PPS? So would you code M0300C1, how would you code M0300C1 on the 5-day PPS? So the number of stage 3 pressure ulcers, is it 0 for A, B is 1, or would you enter a dash? And go ahead and again, you can join on that Slido app and just take a moment and enter your response. I think they're pulling it up on the screen right now. Bear with us, talk amongst yourselves. Sorry, Ephraim, I jinxed you. Well, I think I'm going to just ask you for a show of hands. How many say it's A? How many say B? Woo-hoo, okay. The answer is B. All right. And how would you code M0300C2 on the 5-day PPS assessment? This is the number of these stage 3 pressure ulcers that, there we go, that were present on admission. So number of these ulcers that were present on admission, is it A0? Is it B1? Is it C, enter a dash? So again, we'll do a show of hands while we're getting our software cooking here. How many of you say A0? How many of you say B1? Yeah, excellent. All right, perfect. Oh, we did have folks that are online who are clicking along with that. Great. Okay. Alrighty, and our rationale for that item. So the resident had the pressure ulcer in that same anatomical location prior to transfer to the hospital, but because the pressure ulcer increased in numerical stage to a stage 3, it's going to be coded as a stage 3 present on admission or entry. Your coding tip to support this is on your manual page M9, where it says if a resident had a pressure ulcer injury, is hospitalized and the ulcer increases in numerical stage or becomes unstageable due to slough or eschar, it will be coded as present on admission on reentry. All right, next scenario. A resident is admitted to a nursing facility with a short leg cast to the right lower extremity. He had no visible wounds on admission, but arrives with documentation that a pressure ulcer exists under the cast. 2 weeks after admission to the nursing facility, the cast is removed, and following the removal of the cast, the right heel is observed and assessed as a stage 3 pressure ulcer, which remains until the subsequent assessment. So whether that subsequent assessment is the 14-day or at admission, whatever it is, how would you code M0300C1 on the subsequent assessment? Number of stage 3 pressure ulcers. Would you code it as A0, B1, or C, enter a dash? And go ahead and take a moment. Those of you who are online or in the room, we're glad to have you participating. It's really cool that the online folks can participate in the polling too with this. All right, we still have a couple more coming in, but it does look like it's a pretty strong vote for 1, right? We're going to code M0300C1 on the subsequent assessment as 1. And how many of these ulcers are you going to code in M0300C2 on the subsequent assessment? So coding the number of these stage 3 pressure ulcers that were present on admission, entry, or re-entry. Would you code A0, B1, or C, enter a dash? So go ahead and take just a moment there and enter your answers. Again, would you code what is the number of these stage 3 pressure ulcers that were present upon admission, entry, or re-entry? We've got lots of folks still clicking in. And it does look like an overwhelming majority are saying 1. So that pressure ulcer, the resident was admitted with a documented unstageable because of the non-removable dressing or the device. They had a cast. And then when they removed that cast, the stage 3 pressure ulcer was assessed. It was the first time that ulcer was assessed, that it had been numerically staged, so it is coded at that stage, the stage 3, present on admission, entry, or re-entry. Okay, next scenario. Mr. M was admitted to the nursing facility with eschar tissue covering both heels, as well as a stage 2 pressure ulcer on the coccyx. The pressure ulcers were reassessed before the subsequent assessment. The stage 2 on the coccyx had healed. The left heel eschar had become fluctuant and showed signs of infection, had to be debrided at the bedside, and was subsequently numerically staged as a stage 4. And the right heel eschar remained stable and dry, and it remained unstageable. So how many stage 4 pressure ulcers will you code? How would you code M0300D1 on the subsequent assessment? Would you code A0, B1, or C, enter a dash? Okay, it looks here like the overwhelming majority says that they're going to capture 1 ulcer, and you guys are right on with that. And then how would you code M0300D2 on the subsequent assessment? And this is the number of these stage 4 pressure ulcers that were present upon admission, entry, or re-entry. Would you code it 0? Would you code it B1? Would you code it C, enter a dash? Now, how many were present on admission, entry, or re-entry? We have the majority here are saying 1, but a lot of folks are saying 0 as well. So let's look at the answer and see what we come up with here. The correct answer is 1, and let's talk about the rationale for that. Oop. Oh, wait a minute. What am I doing here? Sorry about that. Okay, so again, one of these ulcers with slough or eschar was present on admission or reentry. And let's look at the rationale. So we're going to code one ulcer as a stage 4, and we're going to code one ulcer as unstageable. Both are going to be present on admission. Remember, the stage 2 on the coccyx is healed. So Mr. M was admitted with an unstageable. One of the heels was subsequently debrided, and that first numerical stage is a stage 4. Thus, that's going to be coded as present on admission at that stage 4. And again, the other heel ulcer remained covered with eschar. Okay. Our next one, a resident's admitted to the nursing facility with a blood-filled blister on the right heel. After assessment of the surrounding tissues, it's determined to be DTI. 3 weeks after admission, the right heel blister is drained and conservatively debrided at the bedside. After debridement, the ulcer on the heel is staged as a stage 3 pressure ulcer. On the subsequent assessment, it remains a stage 3. So how would you code M0300C1 on the subsequent assessment? So this is the number of stage 3 pressure ulcers. Would you code it A, 0, B, 1, or C, enter a dash? And the lion's share of folks are saying B here. We've still got a few votes coming in, but you are right. Oh, whoops, too fast. It is B1. And then how would you code M0300C2 on the subsequent assessment? The number of these stage 3 pressure ulcers that were present upon admission or entry or re-entry. Would you code it A, 0, B, 1, or C, enter a dash? Lots of folks are still voting, so we'll give it just another moment or two. Okay, and it looks like most of folks have said B, and that is the correct answer, and let's look at the rationale. So this resident had an unstageable pressure ulcer due to deep tissue injury. Then that was subsequently debrided. So the first time it's debrided and staged, it is a stage 3. So it was, remember, person was admitted with unstageable. The first time it becomes stageable, it's again going to continue at that stage as present on admission. Now what if 2 weeks later it goes to a stage 4? Present on admission? No. You got it. Good job. Okay, and then we have Mr. H. He was admitted with a known pressure ulcer or injury due to a non-removable dressing. 10 days after admission, the surgeon removes the dressing and a stage 2 pressure ulcer is identified. 2 weeks later, that pressure ulcer is a full thickness ulcer, and it's now staged as a stage 3, and it remains a stage 3 at the time of the next assessment. So how are we going to code M0300C1 on the subsequent assessment? Number of stage 3 pressure ulcers. Will we code it A0, B1, or C? Enter a dash. And it looks like about 94% of you all say that it's B1. So then with this one stage 3 pressure ulcer, how would you code it in M0300C2 on the subsequent assessment? The number of these stage 3 pressure ulcers that were present on admission, entry, or re-entry. Would you code it A0, B1, or C? Enter a dash. We still have quite a few votes coming in. Give it just a moment or two. Okay, looks like most of you are saying 0. And that's correct. Let's take a look at the rationale. So our resident came in with a unstageable because it was covered with a dressing or device. Then the device or the dressing was removed and we see a stage 2 pressure ulcer. And then prior to our next assessment, it actually worsens to a full thickness wound and it's now considered a stage 3. All right, let's talk for just a moment about the cross-setting pressure ulcer measure. It's called Changes in Skin Integrity, Post-Acute Care, and it's Pressure Ulcer Injury QM. You can find the data specifications for this. The document's called Final Specifications for SNF QRP Quality Measures and Standardized Resident Assessment Data Elements. This measure was finalized in the fiscal year 2018 SNF final rule with the implementation of October 1st, 2018. So just a couple months away. Can't believe I'm saying October's a couple months away. My word. Before you know it, we'll be wearing snowsuits, right? Instead of flip-flops. So this measure meets the Impact Act requirement to address skin integrity and changes in skin integrity. It's a cross-setting measure that reports residents who since admission have had a new or worsened stage 2 through 4 pressure ulcer or an unstageable pressure ulcer due to slough or eschar, non-removable dressing, or DTI. So what's the big change there from our current pressure ulcer measure? Any thoughts on that? We're including the unstageables, right? That's a big change. Another big change is now where we're looking at from the timeline, and I mentioned to that earlier. So M0300 items will be used to calculate this QM with data collection beginning October 1st, 2018. We actually already collect all these data. It's not a change for us. There's some minor changes where we've added device and things like that, but otherwise you guys are familiar with these items. And do remember that there is some pretty significant new coding guidance related to the unstageables. Dash use, I want to just mention. A dash is an accepted value for these items. However, we would expect dash use is pretty infrequent. I would think it would be pretty unusual that you wouldn't know your patient's skin status. What might be an example of it? The person's in your nursing home for like 10 minutes and goes back to the hospital or something. But otherwise, I would think you would know what these items are. So let's look at the numerator and denominator. The numerator is residents who have a complete Medicare Part A stay for which the discharge assessment indicates one or more new or worsened stage 2 through 4 pressure ulcers or unstageable pressure ulcers due to slough or eschar, a non-removable device or dressing or device, or DTI compared to admission. So it's 2 points in time now, guys, that first assessment and the discharge assessment. The SNF denominator is the number of Medicare Part A SNF stays in the selected time window for residents ending during that time window, except those who meet exclusions. So who is excluded? Residents who have missing data, or if the resident dies. So again, your resident, if you dash these items, they are excluded. But if I'm looking at your MDSs as an auditor or something and you've got a lot of dashes, I'm saying what is going on in your world here that you can't complete these items. That would be a giant red flag to me. There are some risk adjustments. These are pretty similar to what the risk adjustments were in the other measure. The first is functional mobility. This is a change. We're now using GG0170C, which is lying to sitting on the side of the bed for the covariate for this. So think about covariates are, these four things are issues with that resident. They're resident level issues that increase the likelihood of them having a pressure ulcer. It's not an exclusion. These guys don't come out of the numerator or denominator, but it kind of levels the playing field based on residents' risk. So we're looking again, functional mobility. If folks are dependent, need substantial or maximal assist, if the resident refused or it's not applicable or not attempted, that is going to be the credit for the covariate. Bowel incontinence, if the resident's occasionally, frequently, or always incontinent of bowel, that is the covariate, so that's a 1, 2, 3. That's consistent with how it's always been with the pressure ulcer measure. The next is PVD or PAD, so peripheral vascular or peripheral arterial disease, which are I0900, and I2900 is diabetes. If either of those are checked, that is the covariate. And then BMI. So the BMI doesn't appear in your MDS, but it is calculated with the height and weight. So the covariate is if the BMI is less than 19, equal or less than 19. What about the time window for this? It's calculated using a rolling 12-month window. If a resident has more than one stay during that time, each stay is eligible for inclusion, and that's an important fact. That's an important point. More details are available in those QM specs that I just mentioned. So, what did we accomplish in this little over an hour together? We looked at the updated coding guidance and some examples, as well as the cross-setting pressure ulcer measure. Keep in mind that's expanded now from 2 to 4 pressure ulcers, stage 2s through 3s and 4s, to include those unstageables, and that measure is meeting the Impact Act requirement. So it's time to test your Slido skills with some ideas for your action plan. So in your folders, you have an action plan, and there's a part of that action plan for each section. So it looks like this. If you're online, it is in that introductory folder. So there's an example there that's related to a drug regimen review. You certainly can think about that. So if you could, go ahead and pop in an idea or two in Slido. Let's see who has the fastest typing skills on those little phones and can share their ideas for Slido. We decided when we prepared this training that many of you guys have been doing this as long as many of us have, and your ideas for the action plan were at least as good, if not better than ours, so we thought we'd look to you rather than you all looking to us. So please share those ideas. Ephraim, are we pulling up Slido or? Educate new staff on new MDS changes. Use a mannequin for demonstration in training. Training for wound care guidelines for all wound nurses. I would argue to expand those training for all nurses, because the wound nurse leaves or comes on the floor and automatically all the other nurses' wound care brains are sucked out of their head, right? We want everybody to know. Does the discharge MDS, we have a question there. I'm going to hold on that one, but put it in with the questions, if you will, instead of the ideas. So lots of ideas. again, reviewing the intent, rationale, the steps for assessment. There's lots of new coding tips that you're going to see in Section M, and you're going to see a much shorter Section M than you used to. I must say some of my very favorite items retired, the things I've loved to train on, so I had a bit of a sad time, but realized they're not being used, so hopefully you're capturing those measurements and things in your clinical information. So I am about to get the hook. I was just told I have 2 minutes remaining, so if there are any questions, the one is, does the discharge MDS include the standalone NPE? So the NPE, I do not think, actually I'm going to look to Deb Weiland. Can you help me with that, Deb? So I don't understand what we're asking here, I guess. Does the discharge MDS include the discharge MDS? Anyway, see us on the break if we can help with that. And with that, I think Tom's going to come see us. I want to thank you guys for your attention, and I appreciate it. I'll see you guys tomorrow at the end of the day.